My name is Dr. Jonathan Fialkow. I'm a cardiologist in South Florida. I'm board certified by the American College of Cardiology and Cardiovascular Medicine, and I'm certified by the American Board of Clinical Lipidology. I'd like to spend a few minutes discussing the significance of the ENHANCE study, which was released in January of 2008. The ENHANCE study was a study which compared the benefits of simvastatin, also known as Zocor, at a high dose of 80 milligrams, compared to simvastatin at 80 milligrams with an additional medication called ezetimibe, also known as Zetia, the combination of which is known as Vytorin. This study was completed several years ago and was performed in Europe. Over 700 patients with an extremely rare genetic lipid cholesterol elevating abnormality were studied, and in these patients, half were given the simvastatin by itself and half were given simvastatin with the addition of ezetimibe to further lower the LDL cholesterol. Over the 2 years, multiple measurements were taken in these patients of the thickness of the artery wall in their carotid arteries, which is a large artery in the neck, using that as a potential indication of whether they had improvement in their arteries throughout the body. At the end of the 2 years, it was determined that there was no statistically significant difference, meaning no major difference between the progression of blockages in the group that received the simvastatin by itself and those who received the additional cholesterol-lowering agent. These data were subsequently released after some time and recently reported on, and to my understanding, there might have been some misperceptions and miscommunications regarding these data, and I would like to describe exactly how I perceive the data and would use them to treat my patients. The first point to be made is that the patients studied in this study were extremely rare when it comes to their cholesterol abnormalities, generally felt to be less than 0.2% of the population. The mean LDL cholesterols in these patients was well over 300 milligrams per deciliters. That's just the LDL cholesterol, not the total cholesterol. These are not the average person who's walking around with elevated cholesterol who's being treated by their physician. In these extremely high-risk patients, those that received the medical therapy with simvastatin had a 40% reduction in their cholesterol, and those that received the combination had a 56% reduction, which did lower the LDL cholesterol further. However, both groups wound up with LDL cholesterols persistently much higher than we in our population of patients would accept as adequate treatment. So make note, these were very high-risk patients with very severe genetic abnormalities leading to very high cholesterols, and even despite the medical therapies, they remained with cholesterol levels that remained quite high. The second point is that they used a measurement of an artery in the neck as an indicator or a surrogate for cardiovascular events. What we really want to know is, did people who got the combination therapy have less heart attacks, strokes, bypass surgeries, and things that vascular disease can actually lead to? And there was no difference in these events between the two groups. Both groups had a very slow progression in vascular disease as measured by the thickening of these arteries. So both groups worked. There was no statistically significant difference between the two groups, suggesting against a particular benefit of the additional medication in this group of patients using this marker. Perhaps, had they kept the study going for longer, 3, 4, 5 years, they might have seen a difference, as these were high-risk people and the cholesterol lowering might have taken longer to show a significant difference between these. But that's not the information that we have right now. So, what are the issues as discussed? What are the issues as presented by this study? Well, number one, in consequence, a lot of people were concerned that the medication they were taking perhaps didn't work and might even have been dangerous. One should not discontinue the use of a medically prescribed therapy without discussion with their doctor. Many times medications are given for a particular reason. Many times they are dosed because of being taken with other medications, and to abruptly stop a medication would be inappropriate, and one should discuss this with their doctor. The second point is that the group that received the simvastatin by itself did have a slow progression of disease, as did the other group. But these high-risk patients had very slow progression in the blockages, so perhaps both medical groups did work. The statin drugs like simvastatin have been studied for over 20 years with excellent safety records and outstanding medical data supporting that they do decrease the risk of stroke, do decrease the risk of heart attack, do decrease bypass surgeries in their respective groups. These medications should be used first line, and they should not be discontinued or stopped due to another cholesterol medication out there which has not been shown to be superior. Ezetimibe, which is currently FDA approved for the use in the United States to lower cholesterol, can be used safely as an adjunct or in addition to a statin-lowering therapy, but certainly should not be taken off the market or stopped inappropriately without discussion with their doctor. There are studies that are being done looking at the benefit or risk or neutral effect of adding ezetimibe to a statin in patients with more usual cholesterol elevations to specifically look at the elimination or decrease of vascular events, specifically heart attacks, bypass surgeries, strokes, etc. And when those data are released, we should have a better understanding as to what the role of this additional medication is. But once again, right now it can be used safely in combination with statins or in patients who cannot tolerate statins, but should not really be used in place of statins based on the data presented so far. Hopefully this helps explain and clarify why this particular study should not necessarily change the way we are currently practicing medicine in the United States based on the medical data, and hopefully should reassure all those who have been taking these medications that there is no evidence of danger or risk from doing so. Thank you.